So good morning. My name is Lyle Best. I grew up in Wapton, North Dakota, worked for the Indian Health Service as a family physician for a little over 20 years, from 77 to 98, and then worked part-time in a local clinic for another 10 years in the Turtle Mountain area in North Dakota. I began working with Strong Heart Study in 1998 and also began doing a couple other genetics projects. I taught genetics at Turtle Mountain Community College for a little over 10 years and have been involved in other research projects besides Strong Heart, including the one we'll talk about today having to do with asthma and another having to do with genetics of a condition called preeclampsia or toxemia of pregnancy. So there'll be a couple other collaborators. Dr. Torgerson is going to join us later, and she'll introduce herself. But Dr. Erdai is at the University of New Mexico, and she began work about 10 years ago with the Missouri Breaks in the Cheyenne River area. She's an immunologist and interested in how our immune system works, and most recently been working with investigating possible toxic exposures in the Cheyenne River and South Dakota region and how that might affect your immune response. She's also been working with the Navajo and what's called the Navajo birth cohort down in New Mexico. And most importantly for this particular presentation today is Ray O'Leary, who works for Missouri Breaks. She's a respiratory therapist and have been working with Dr. James Wallace, a pulmonologist down in South Dakota, for a number of years, and I became familiar with her through my work with the Strong Heart Study and the Missouri Breaks. So she was interested, she and Dr. Wallace were interested in seeing if an intensive educational program for children with asthma could help reduce the complications, the number of times they'd go to the emergency room, the number of times they're in the hospital, and so on. And they had some evidence that seemed to be indicating this was a pretty powerful way to make it a little bit easier to control asthma for these children. But it's not been done as what's called a randomized controlled trial, which is really the kind of the gold standard of how we develop evidence to know that a particular treatment or something is actually working. So when I heard about what she and Dr. Wallace had done, and there was an opportunity to develop another study with Dr. Amy Elliott at Sioux Falls. And we decided to try and conduct a randomized controlled trial to prove that this educational effort really does make a difference. And so we had recruited about 104 children with asthma, and the plan was to divide them into two groups, one that would be exposed to this new intensive educational program, the other would be exposed to the usual care, which is generally consisted of, visits our doctor from time to time and written pamphlets and so on. And then we would follow these children for a couple of years to see how many emergency room visits or hospitalizations they might have. And we did conduct this as part of the FIPA study, and we did see a protective effect at about 1 year, but that effect seemed to go away over time. And I think the lesson from this is that you really need to have a continuing, ongoing educational program in order to see the continuing benefit of this type of education. So that was one of the first results and developments from the FIPA study, the original FIPA study. The other part of it is we were interested to know if we could find out if there were any environmental factors, for example, that might be increasing the risk of children's having asthma or perhaps preventive in some way. And we were interested to know a little bit more about their immune response, whether they had specific allergies or whether it was inflammation in general that was generating this asthma for them. And so we did some blood tests and so on for that. And also we did some collecting of DNA so we could look to see if there were any genetic factors that might be, again, influencing the risk of asthma. So beyond the 104 children with asthma, we recruited 2 other children for each child with asthma. And these children did not have asthma. so we could compare those with and without asthma. So what we found was there were some differences between the two groups, and in terms of their immune response, we did see an increased level of what we call IgE. This is a special antibody that is often increased for people that have allergies to a particular substance. It's also often increased in people that have eczema, for example, where the immune response is kind of overactive. We also noticed that the children with asthma were more likely to be overweight and obese. And this has been seen in other populations as well, as it's not just limited to the American Indian population in the Cheyenne River area. And that's the same for these other immune measures that we took. The DNA was examined, as mentioned, and we tested 10 different very small changes in the DNA that have been seen to be associated with risk of asthma in other populations. And of these 10, there were 5 that did show the same effect in the Cheyenne River study. So those were in 2 different chromosomes, number 17 and number 5, which you just see here in a picture of the different chromosomes spread out. Around this time, or a few years later, actually, we became acquainted with Dr. Torgerson, who you hear from in just a few minutes, and she was kind enough to provide some funding for us to do further genotyping or testing of the DNA on these children. And instead of testing merely 10 different changes, we actually tested nearly 2 million changes of the DNA on each child. And this was done down at the University of Colorado. And this data is very valuable, and it is now belonging to the tribe and is part of the legacy from this research. The analysis is still going on, but in general, what we find is that there are a number of changes in this additional data that are similar to what we see in other populations with asthma, and some that are somewhat different. But again, the analysis is still going on. But I think in the long run, what we're going to find is that we'll be able to distinguish a little bit between different kinds of asthma. It could well be that some people have a cause of their asthma that is somewhat different than the next person. And what this might be important for is it could be there's different medications that work better in this type of asthma as opposed to that type of asthma. So these are the kinds of things that we hope to be able to look into further with this additional data. So one of the things we're always dedicated to in Strong Heart study, Missouri Breaks in particular, and this asthma study, is returning results to the participants. That's part of what we're doing right now today, but also individually. So those individuals who come in for their exam, for the study, and so on, they are given further information that can hopefully help their health in terms of some counseling about better eating habits and nutrition, encouragement to stop smoking, of course, and certain ways to control their asthma a little better, using their medications a little more effectively, and so on. Dr. Ray O'Leary, who we mentioned earlier, and I developed a Red Talk, which was on their YouTube, and that you can access through the Missouri Breaks website. And we had community meetings such as this one that we're trying to record today. So what about that genetic information? As I mentioned, we tested some nearly 2 million different changes in the DNA. We obviously are not going to give all of that information back to every individual. Most of it is not of any use to them specifically. It might be useful from a research standpoint, but for their health and for their doctors to make any changes in their treatment, it's really not going to be useful to them. But there are some parts of that have been found to be useful to physicians taking care of their patients, and these are what we call clinically actionable. So it's something that you could take to your clinician, your doctor, your healthcare provider, and they'd say, "Oh, that's interesting. I think maybe we should do things a little bit differently in terms of your health, your treatment, and so on." So we took a look at this large group of 2 million some changes, and we picked out just those that could be clinically actionable in this way. These were a list developed by American College of Medical Genetics and so on. So what we found was there was two individuals amongst the 300 some children in the study that did have a change in a particular gene called the MYH7 gene. And these changes have been known in other populations to increase the risk of something called cardiomyopathy, which is a serious heart condition. The good news is it is a condition that can be controlled to some extent if you know about it, and controlling your blood pressure in particular is very important for these individuals. So we explored how should we go about contacting these individuals. There was some thought that perhaps it should be done in some sort of community-wide way. And the more we talked about it, not only with members of the community, but also with the tribal council and the health committee, some of the local physicians at the Indian Health Service, and also the staff at Missouri Breaks, it was decided the most direct way and the simplest and best way was simply to go to these two people and talk to them specifically about what we found. And that was done. One of the individuals was interested in following up further, and she was arranged. We arranged for a cardiac ultrasound for her in Rapid City. I think that was luckily everything looked good at that point. We counseled her about the future, that she needs to be sure to maintain a good blood pressure control and so on. The other individual was not interested in further follow-up and so on. But I think this is somewhat unusual. This is not done in many genetic investigations like this, but we felt it was important to make sure that what we did know in this case were communicated back to the individuals if it could make a difference in their healthcare. Well, at this point, I'm going to turn things over to Dr. Torgerson to continue on.
So I'm Dara. I grew up in Pinawa, Manitoba, but now I'm at the University of California, San Francisco, a few other stops along the way. I did my PhD in biology, and I started studying asthma in 2009. Not entirely coincidental. One of my interests was because I also have asthma myself. So one of the things that we know about asthma is that oftentimes exposure to respiratory syncytial virus, particularly as a young infant, if someone develops a severe infection, that child is actually much more likely to develop asthma by ages 6 or 7 or even earlier. And so we believe that there's something that that changes in an individual that makes them more prone to develop asthma after severe RSV infection. And so when thinking about asthma being a multifaceted and multiple things that contribute to the development of asthma, not one specific thing, we wanted to also look at how individuals' immune response might have been different from prior exposures to RSV. So first of all, we wanted to see if it was actually something that might be of importance to look at. So among individuals with and without asthma, parents and guardians were asked the question, has your child ever been diagnosed with RSV? And we found that children with asthma, their parent and guardians were more likely to say yes. So we found about 35% of kids with asthma had a prior diagnosis of RSV by a healthcare professional, as compared to only 16% of children without asthma. We also noticed that children with asthma were more likely to have been hospitalized with RSV. So this is actually a pretty high rate. Close to 18% of children with asthma had a history of being hospitalized for RSV versus 7% in children without asthma. So this was telling us that there probably was an increased burden of RSV in children with asthma. Not necessarily that RSV was leading to asthma, but that this was something that we might want to look into a little bit more in the FIPA study. So when we started to look at immune antibodies to RSV, so our antibodies help us to get recognize and to get over RSV infection, we looked at a very specific type of an antibody, so immunoglobulin G. And we found that actually, interestingly, that children with asthma actually had lower levels of this antibody to RSV, but really only we observed that for children that were brought into the study during the winter time when we know that RSV was circulating more broadly. And so this compared to asthma controls, where we found that they had higher levels of antibodies to RSV. But we also observed about 12% of asthma controls. It didn't look like they had even been exposed to RSV yet. And so this was telling us either that there's a different immune response or there's a different exposures. And that, again, this was something that may be relevant for us to look into. But we couldn't really tell why. And so this is, always the question in science is, okay, we've made this observation, but why are we seeing this? And, what can we do about it? So this really spurred us to say, hey, we should try to look at this a little bit more because, we're not, because it's such a multifaceted disease, it's not any one thing that we should be looking at and saying, okay, if we fix that, we will solve asthma in the community. And so we started a new study because one of the things we realized is that there were actually a large collection of viruses that not only may contribute to the development of asthma, but are also of higher clinical burden so that children with asthma are more likely to get sicker and also to have persistent wheezing and kind of an uptick in asthma symptoms during and after viral infections. So we wanted to look at this a little bit more. We also realized that we needed to look at some additional factors too that weren't necessarily captured in the first study. And so we decided to together as a study team to recruit additional children with and without asthma. And this was adding another study site in Rapid City as well as Eagle Butte, so we could start to look at urban versus rural, uh, factors, and then also recontacting original FIPA 1 participants that were now adults. So part of this is that we know that asthma is not guaranteed. It's not, if you have asthma as a child, it doesn't mean that you are going to have asthma for the rest of your life. Symptoms can come and go. Our environments change. We wanted to really kind of capture, okay, now what is happening now? So if we can look at longer term outcomes, that's also something of importance to learn more about asthma. And so around this time, original FIPA 1 participants were adults and becoming adults, and some also having children of their own. And so we also know there is a inherited component of asthma too. So we wanted to dig a little bit more deeper into that. And another thing that we wanted to start looking at more so is the role of the immune system. So not just measuring antibodies to viruses, but also to look at general signaling proteins to see, okay, what is actually happening in terms of the immune system? Is there immune dysregulation, and what could be contributing to that so that we could identify things that maybe for another intervention beyond that of the Asthma Breathe educational program. We also offered the option to store samples for future studies. So that's one of the things in science. Sometimes you end up, I think, ending up discovering more questions than answers in many ways. And so, we are sort of committed to continuing to address some of those questions and to learn about what new questions are important as we go. And then we also brought along onto the team Dr. Nita Thakur, a colleague of mine at UCSF, who has really brought in a lot of expertise and experiences in terms of social determinants of health, because this was not data that is easy to capture correctly, but we also know that this is probably something that is likely to be of importance, and we see that in many, many different examples where our social and environment is actually really important and can affect our health. And so essentially our hypothesis was that these social and environmental exposures are not just, directly connected to asthma, but the reason that they're leading to asthma symptoms or increased medication use or ER visits or more severe asthma is that these stressors and viruses, they're actually affecting the immune system and in different ways. And it's that immune dysregulation then that causes these asthma symptoms. And so we really wanted to capture some information because we felt it was important. And also if we can figure out, well, which ones might be more important in terms of leading to more severe asthma, then that helps us think about priorities of how we could potentially develop a future intervention. And so one of these data points that we wanted to look at and factors that we wanted to think about were adverse childhood events. And so Dr. Thakur had developed, this is now utilized all throughout pediatrics, well child visits in California. It's also now more recognized that stressful events in our life have a huge impact on our health, and it's something that we can do something about. And so we've started to collect de-identified information through a screener so that we can try to capture some of this information in terms of life events leading up to when a person is enrolling in the study, so that we can start to see if these are factors that may influence respiratory health. Another area that we're looking into is not just the social environment, but also the physical environment. And so we received some pilot funds from the UCSF Earth Center here, and we've started to screen for environmental toxicants in children with and without asthma. So in particularly PFAS, as well as untargeted suspect chemicals. So that we can see, okay, are there differences in exposures and where might those exposures then be coming from? And also, what might those exposures mean in terms of respiratory health? And if we can narrow in and identify some of these, then maybe there are things that we can do. So for example, thinking about filtering water, filtering our air, changes in specific behaviors that could make some differences to respiratory health. And so with that, there's definitely more to come. We are also wanting to think a large number of individuals. I think that the first and foremost, there's been a lot of effort from FIPA participants and their families getting to the clinic, agreeing to participate in the studies, giving feedback on ideas, what are their needs, what questions do we have, what questions should we be asking, bringing their child in to ask a questionnaire and spending several hours. So first and foremost, very a large thanks to the study participants. A large number of individuals on the study teams at Missouri Breaks, some of which we already mentioned, also at UCSF and University of New Mexico. And then a large number of other individuals have been really involved in guiding, as well as community advisory board, in guiding some of these questions and the research that we do. And then funding, of course. So this research is not inexpensive. So the National Institute of Health has given a significant amount of information to fund this research, as well as their center at UCSF to go into new areas. And then with that, I'd like to also thank everybody for listening.